A very good morning to one and all. I am Dr. Durga, Associate Professor, Department of Obstetrics and Gynecology, Sri Lakshmi Narayana Institute of Medical Sciences. We shall discuss our topic, multiple pregnancy. We shall first discuss on the genesis and the etiology of multiple pregnancy. When more than one fetus develops simultaneously in the uterus, it is called multiple pregnancy. The commonest one are the twins. We do have triplets, quadruplets, quintuplets, sextuplets, which are very rare in occurrence. The study of multiple pregnancy is called Etiology. Speaking about the incidence, according to the Helens rule, the incidence of twin pregnancy is 1 in 8 to the power of 2 pregnancies. The incidence of triplet is 1 in 80 to the power of 3. And for quadruplets, it is 1 in 80 to the power of 4, and so on. The current incidence of multiple pregnancy or gestation is about 3% in general population. The occurrence of twins in multiple gestation is 94%. In twin pregnancy, depending upon the zygosity, that is the type of conception, we have different classifications like dizygotic twinning and monozygotic twins. Depending on the chorionicity, which is called the type of placentation, we have dichorionic or monochorionic pregnancies. Now, this is a picture which will tell you or explain you how the presentation or how the occurrence of dichorionic diamniotic twins and monochorionic diamniotic and monochorionic monoamniotic twins occurs. So basically, after fertilization takes place, from the day of fertilization, which is the 0 or the 0 day we call, up to 4 days, within which if any division or cleavage takes place in the blastocyst, it leads to the formation of dichorionic diamniotic twins. That is, both the chorion and the amnion splits or cleavages. The first one to cleavage is the placenta, that is the dichorionicity, and then comes the amnion, which is called as diamnionicity. If the cleavage takes place between 4th and the 8th day of fertilization, after fertilization, the chorion will not divide further. So it stays as monochorionic thereafter. Only the amnion splits in the division which takes place in 4 to 8 days. Hence, we call it as monochorionic diamniotic pregnancies. Suppose the division or the cleavage takes place after 8th day, that is within 12th day, 8 to 12 days of fertilization, there is no more cleavage of chorion and amnion. So what happens? It leads to the formation of monochorionic monoamniotic pregnancies. Now this monochorionic means there is single placenta. You see here in the picture, the placenta is same. In the picture, you see one dividing line here, which is called, that is the amnion. Hence, we call here it as diamniotic. Whereas in this picture, there is no inter-dividing membrane or the amnion. So this is called monoamniotic. So this type of monochorionic pregnancies are quite dangerous when compared to dichorionic pregnancies because of the inherent communication of blood vessels from one baby to the other. So that leads to the formation or to the idea behind the twin-to-twin transfusion syndrome pregnancies. Hope this is clear for you. Now what happens if the cleavage takes place after 12th day? So there is no cleavage of chorion and there is no cleavage of amnion. Then what happens? It leads to the formation of what is called conjoined twins, as you see here. The two babies are fused here at the level of thorax. It's called thoracophagus. And pyophagus, craniophagus, ischiophagus, depending upon the level of fusion, okay, and the level of division, we name the twins like that. Now we shall go into what do you mean by dizygotic twins or fraternal twins, otherwise called biovolar twins. Now the commonest one, as I told you, dizygotic means two different zygotes, correct? 2/3 of the twins are dizygotic twins. Here, first fertilization of two different ova takes place by two different sperms. Hence, the two babies do not resemble each other. Placenta remains separate or sometimes fused at the margins. And there is no anastomosis or abnormal communications between the fetal vessels. As you see in this picture, there are two ova, two sperms, and two babies, which two separate placenta here. Here is one placenta, here is one placenta, and two amniotic membrane, and you have the interdividing membranes here. So you see in the center, it's a light pink color, the two chorions, and then the two amniotic sac is there, and the baby is lying comfortably within that amniotic sac. So this is called dizygotic, which is the commonest one. So how will be the presentation of what is the type of twins we call here? We call it as dichorionic and diamniotic, that is DCDA. Coming to the monozygotic twins, otherwise called the identical twins or uniovular twins. This constitutes to 1/3 of the twin pregnancies. What happens here? Division of one fertilized ovum into two different embryos. Here only the division, depending upon the stages of division, if it takes place less than 3 days or 72 hours, we call it as diamniotic, dichorionic. If it takes between 4th to 8th day, it is called monochorionic and diamniotic. If it takes between 8th to 12th day, we call it as monochorionic and monoamniotic. If the division takes place greater than 12 days, we call it as conjoined twins. So this type of babies which are formed as a result of splitting of one fertilized ovum into two different embryos will always be identical twins. So this is the monozygotic identical uniovular twins. So how will be the presentation in this type of monozygotic twins? Either it could be DCDA, dichorionic, diamniotic, or it could be monochorionic, diamniotic. So this is called monochorionic, diamniotic, or it could be monochorionic, monoamniotic twins. This type of conjoined twins, as we already saw, takes place when the division takes place after the 12th day of fertilization. So this is a picture which will tell you the placental morphology in twin pregnancy. This is monochorionic. That means one single placenta. This is here where you see a single placenta, correct? And which could be monoamniotic, in the sense it has only one gestational sac here and the two babies develop here. Or it could be diamniotic. This is two placenta here, where you see here two placenta. So okay, this type of thing will come under dichorionic and diamniotic. We shall now see two different terminologies called superfication and superfecundation. Derived, what is called superfetation? It is derived from separate ovum and separate act of coitus during different intermenstrual periods. That is called superfetation. Superfecundation means fertilization of two separate ova during the same menstrual cycle by separate act of coitus. Now, determination of zygosity. Why we must know the zygosity of the twins? What is the importance behind that? Why we must know it is dichorionic or monochorionic or diamniotic or monoamniotic? What is the reason behind that? The importance is there is increased risk in monochorionic twins. The risk stratification has to be done. There are high incidence of malformations and screening becomes essential in monochorionic twins. There should be increased surveillance, antepartum fetal surveillance of the two babies in monochorionic twins. Then there are increased risk of transplantations. Now, how can we diagnose multiple pregnancy? Which is the most accurate method? Of course, it is the ultrasound, which picks about 90 to 100% of multiple gestations in the first trimester. If you see in an ultrasound two yolk sacs, it means two amnion, that is diamnionicity. Where do you see here? This is an ultrasound pic at about 7th week. At 7 weeks, where you see two sacs here, correct? There are two sacs. So, and the babies are developing there. So, these are called diamniotic and dichorionic twins. Usually, it is dichorionic. When there are two separate placenta, it indicates dichorionic placenta. Now, how can we predict dichorionicity in an ultrasound? The sign is called twin peak sign or the lambda sign. The triangular projection of trophoblastic tissue. It's isoechoic with the placenta localized into intervening membrane. 100% predictive of dichorionicity. We see some placental tissue projecting. Okay. This is a picture. Hope you can see this. You see this triangular peak of villi which contains the trophoblastic tissue which is extending into the in between the two membranes. The twin membrane. This is called the twin peak sign or the lambda sign. This is the ultrasound picture here. Can you see this tissue going inside? This is a developing placenta and the placenta goes here. So this means it is dichorionicity and diamniosity. If you see an intermembrane dividing membrane, we call it as diamnion. And if you see the tissue of trophoblastic going into it, it means it is dichorionicity. So there are two placenta and there are two chorions and there are two amniotic sacs. Inverted T sign, very important to diagnose in something called monochorionic twins. The right angle relationship between the membrane and the placenta. In monochorionic twins, the number of layers are only 2 layers. In dichorionic, it will be 4 layers. Can you see this called inverted? Here, the membrane, which is very thin and it goes at right angles to the developing placenta. That is called the inverted T sign. And there is no chorionic tissue or the chunk of this isoechoic tissue getting in between the membranes. So this type of thing is called monochorionic and it is diamniotic only because you have an interdividing membrane there. So these are the signs which we can pick up in the first trimester. Going to the second and third trimester, depending upon the fetal gender, discordant genitalia. That is, they both are Different sex. It is usually dichorionicity. Inter-twin membrane confirms diamniosity. Hyperechoic membrane greater than 2 millimeters implies it is dichorionicity, which is nothing but the thickness of the in-between membrane. If the chorion tissue goes into the membrane, it leads to thickening of that membrane. So if it is greater than 2 mm, you say it is dichorionicity. On examination of placenta, one common amniotic sac juxtaposed amnions not separated by chorion. It is type of monozygotic twins. Each fetus has distinct set of membranes on its own. It is called dizygotic. This on the histological examination of the placenta will confirm whether what type of chorionicity and diamniosity it is. So what is this? This is a placenta. Where you see here, correct. For example, in dizygosity twins, what do you mean by dizygote means? 2 ova and 2 sperms. They are being fertilized separately. Correct? This is called dizygotic. What is called monozygotic? It is only a single ova and a single sperm which fertilizes and later on cleaves. That is called monozygotic. So in dizygotic, you always see there are 2 separate placenta and 2 this one. No? So what happens? Placenta tissue goes inside. So here the thickness will be greater than 2 mm as we see in the ultrasound picture. So this is amnion and chorion on both sides and decidua in between. What happens here in monozygotic? Here there are 2 amniotic sacs are here. Okay, 2 amnions and it's diamniotic, but you see it is monochorionic. That is, it does not have the placental tissue dipping into the membranes. So this is mostly called as monochorionic and diamniotic twins. What are the other methods by which we can identify the type of multiple pregnancy? By blood grouping, DNA fingerprinting, and test skin grafts. Speaking about the etiology of multiple pregnancy, the highest incidence of multiple pregnancies reported in the Negroes due to racial variations in the follicle stimulating hormone heredity. Those women who are having a positive family history have a high risk of multiple pregnancy. Inherited tendency to release multiple ova, influenced by autosomal dominant genes. Increasing maternal age increases the incidence of multiple pregnancy. Why? Because at the age of 30 to 37 years, there is maximum hormonal stimulation or the FSH stimulation there. At puberty, there is minimal ovarian activity and incidence is 0. After 37 years, due to depletion of follicles, the incidence of multiple pregnancy is going to go down. The parity. As parity increases, the incidence increases. With more than 4 children, the incidence is going to rise. Maternal body weight and nutrition also has effect depending upon the levels of the pituitary gonadotrophins. Levels of pituitary gonadotrophins. 1 month after sudden stopping of oral contraceptive pills, there is a sudden release of pituitary gonadotrophins, which leads to increased incidence of multiple pregnancy in those women taking OCPs and stopping the OCPs after which immediately they conceive with the twins. Induction of ovulation is another important cause of multiple pregnancy. Use of follicle stimulating hormone plus chorionic gonadotrophin or clomiphene citrate recruits multiple pregnancies. Assisted reproductive techniques where 2 or more embryos are transferred is also another causes another cause of multiple pregnancy. Discussing about the clinical features, the first trimester, there is amenorrhea, a period of absence of menses, increased morning sickness because of the increased levels of beta HCG secreted by the placenta. Frequency of micturition is there. There is breast discomfort and increased fatigability. In second trimester, weakening is felt, progressive enlargement of the lower abdomen, which is more than the expected period of gestational age, easy fatigability, fetal edema. Symptoms of preeclampsia are more common in multiple pregnancy in 25% of cases. In third trimester, patient may complain of palpitation and dyspnea during exertion because of the growing uterus having pressure effects over the diaphragm and due to the cardiovascular system changes which takes place in multiple pregnancy. Frequency of micturition increases and in pronounced fetal movements. So diagnosis of multiple pregnancy is done by a good history taking, clinical examination, ultrasound. Radiological examinations are not done nowadays. It's only for theoretical purposes. Biochemical examination. In history, what we see? Advanced maternal age, high parity, maternal history, family history of twins, or personal history, past history of twin pregnancy, administration of drugs like OCPs, clomiphene citrate, gonadotrophins, and artificial reproductive techniques or the ARTs. General examination, we see pallor, which is more common in multiple pregnancy because of the increasing requirement of iron, fetal edema is there, unusual weight gain, and varicose veins, all because of the pressure effects of the growing uterus. In the picture, we see the unduly enlarged abdomen, which is barrel-shaped, with the dilated veins over the abdomen. Palpation of abdomen, the height of the uterus more than the period of amenorrhea. Greater abdominal girth, too many fetal parts, more than one fetal head, more than 2 fetal holes. Percussion of the abdomen, fluid thrill may be present due to associated hydromenas in 10% of the cases. More common in uni-overlap twins, usually in the second sac. Auscultation is a very important diagnostic criteria. 2 distinct fetal heart sounds with a silent area between and difference in heart rates of greater than 10 beats per minute heard by 2 persons. Ultrasound helps in the confirmation of diagnosis. More than one gestational sac as early as 6 weeks can be identified. The number of fetal holes, the cardiac activity, the viability of the fetuses, presence of fetal anomalies, placental number and localization is very important and can be determined by 100% accuracy with ultrasounds. Ultrasound is also important to determine the amniotic fluid volume and Doppler studies of both babies, especially in case of monochorionic babies or the twins where there are abnormal vascular anastomosis between the twins. So what is in ultrasound? It will help you to detect the monochorionicity. It is the inverted T sign. The dichorionicity is called the lambda or the twin T sign. Radiological examination, taking an X-ray, which is not done nowadays. 2 fetal heads or 2 spines visualized. Biochemical examination, increasing or the doubling titers of serum HCG, alpha-fetoprotein and unconjugated estriol are also increased. What are the complications of multiple pregnancy? Maternal complications during pregnancy, labor, puerperia. Complications during pregnancy are the excessive nausea and vomiting because of beta HCG, which is very increased, anemia because of the increased requirements, PAH, pregnancy-induced hypertension in 25% of the cases, polyhydramnios, oligohydramnios, both can exist, increased instance of preterm labor because of the uterine distension and irritability, malpresentations are common, antepartum hemorrhage, mechanical distress to the mother because of the growing uterus, compressing the movement or compromising the movement of the diaphragm and decreasing the functional resistible capacity of the women. So the anemia, which is because of the increased requirement of iron and folic acid, can lead to iron deficiency anemia as well as megaloblastic anemias. Why there is PAH? Increased expansion of intravascular volume, okay, is there, and there is severe preeclampsia with proteinuria being positive there. Polyhydramnios, more common in the monochorionic, usually involves the larger sac, where there is increase in the cardiac output of the baby, and there is increased renal blood flow to the baby, and it increases the urine output, and therefore polyhydramnios in the bigger sac. The preterm labor, which is often seen in multiple pregnancy, increases the risk of perinatal morbidity and mortality. So how to prevent them is by, or how to overcome them is by giving appropriate amount of tocolytics and in concurrence with the steroids like betamethasone and dexamethasone to increase the lung or to accelerate the lung maturity. Preterm premature rupture of membranes is also there, which is twice the risk. Careful monitoring is essential. So hence, in such cases which happens in multiple pregnancy, avoid digital examination. Okay, give appropriate antibiotics and start steroids. The risk of chorioamnionitis is really increased in such cases. Going to the malpresentations. So what is the presentation which is seen here? Is the first twin, which is having a breech presentation, and the second one going for cephalic presentation, correct? So this is a head up and a head down presentation. So malpresentations are there. There is increased risk of antepartum hemorrhage here because the placenta, which is situated here, sometimes in case of multiple pregnancy, can be attached to the lower uterine segment. So that you call it as placenta previa. The abnormal attachment of the placenta to the lower uterine segment is called placenta previa. There is high risk of abruptio placenta also. It is increased in multiple pregnancy because of the associated preeclampsia. What is called abruptio? It is where the placenta gets separated from the uterus, causing internal bleeding. There is rupture of membranes and there is escape of that liquor along which is blood stained. Other cause of abruptio placenta may be because of the associated folic acid deficiency. So once abruption has taken place, it is an obstetric emergency. It leads usually to the delivery of the baby. Now, what are the mechanical distresses which are present during pregnancy? Other palpitation, dyspnea, varicosities, hemorrhoids. During labor, there is early rupture of membrane and cord prolapse. What are the complications we see during them? Are the early rupture of membranes and cord prolapse, intrapartum bleeding, prolonged labor, increased incidence of postpartum hemorrhage, delay in delivery of the second baby. Premature rupture of fetal membranes with prolapse of umbilical cord. This is another important complication where you see during labor. So suppose if there is a rupture of membranes, what happens in this case, as you see here, the umbilical cord is lying very close to the cervix, whereas the head is very high up. And this leads to the escape of the cord via the cervix. So this leads to a condition called cord prolapse. There is increased incidence of postpartum hemorrhage because of the atony of the uterine musculature, very common because of the enlarged uterus and overdistended uterus, large placenta exposing more uterine sinuses, implantation of placenta in the lower segment. All these are causes of postpartum hemorrhage. So here, can you see the technique which is done to control the bleeding, which is because of atonic PPH? This is called the bimanual compression. Here the obstetrician keeps one hand into the anterior fornix of the vagina, and the other hand is over the suprapubic region, anti-flex, giving a pressure downwards, flexing the uterus upon in between the two fingers, in between the two hands, and trying to compress it. This is called the bimanual compression. During puerperium, what are the complications we see? It is a subinvolution of the uterus, the high risk of infection because of the operative interferences which may lead to pre-existing anemia, blood loss, and high incidence of lactation failure. What are the fetal complications? There are high chances of abortion, vanishing twins are there, fetal papricious, prematurity, fetal anomalies, intrauterine growth restriction and intrauterine deaths, asphyxia, and stillbirths. Abortion is very common in monozygotic twins. What is called vanishing twin? Here, initially there would be two sacs. Later than one sac disappears and gets absorbed by itself. So this is called the vanishing sac. The other one is quite strong enough and it is continuing the pregnancy and it is continuing to grow in the pregnancy. So this is called vanishing sac. Here, if the death of the fetus occurs less than 10 weeks of pregnancy, this type of condition takes place and it proceeds as a singleton pregnancy. What is called fetal papricious? Here, can you see the placenta and you see the baby? The dead fetus is compressed between the membranes and the uterine wall. That is called fetus papricious. Fetal anomalies. These fetal anomalies, as I told you, very common in monochorionic twins. Okay. At the same time, highest constant, very common in univocal twins. Compared to singletons, twins have the high risk of anomalies. Each fetus of a dichorionic twin pregnancy has a risk of structural anomalies such as spina bifida. Even in dichorionic twins also you have certain risks. Anencephaly is a good example of a lethal abnormality that can threaten the survival of a normal twin. High incidence of neural tube defects and congenital heart diseases. Fetal anomalies. Due to teratogenicity are the conjoined twins, acardiac anomaly, neural tube defects, holoprosencephaly, and serenomelia. Due to vascular interchanges, we have the acardiac twins, microcephaly, hydrancephaly, intestinal atresia, aplasia cutis, and limb amputation. Due to fetal crowding, we have talipes equinovarus, congenital hip dislocation, and chromosomal anomalies called fetal aneuploidy. IUGR. Competition for the nutrient in the last weeks leads to IUGR of one twin, and IUD, intrauterine deaths, more common in monozygotic twins. Asphyxia and stillbirths are common when there are other associations of preeclampsia, placental abruption, malpresentations are there, and operative interference. Explaining the risk of prematurity in twins, you see, as twins, triplets increases, the risk of birth of the baby less than 33 weeks is about 41% in triplets compared to 14 here, and very less to 1.7 in singletons, and 14 in twins. So this is the incidence of prematurity increases as the twinning, as the number of babies increase. So what are the problems because of prematurity? The birth weight of the baby is less, hypothermia, infections, respiratory distress syndrome, blindness and retinopathy, patent ductus arteriosus, hyperbilirubinemia, hypertension and hypotension of the baby, anemia, pneumothorax, apnea, cerebral palsy, intracranial hemorrhage, metabolic disorders, and hypotonia. The risk of mortality per 1,000 live births, that's the infant mortality rate, is high as the order of pregnancy increases. In singleton, it is only 11.2. In twins, it is 66%, and in triplets, it is 190 per 1,000 live births. What is called single fetal demise? That is, among the two babies, one baby dies and the other baby grows. This type of problem is very common in monozygotic twins. If this happens in the first trimester, it vanishes itself and it is called the vanishing twin. If it happens in the second trimester, the baby becomes very small and crowded and gets attached to the uterus and the membranes called fetus papricious. Twin fetus that died in utero become flattened and mummified. As you see here, this is a baby which is fetus papricious. What is the risk in such cases? For the second twin, which is developing in concurrent with it, one fetal death before 14 weeks means there is no risk. The fetal death occurs after 14 weeks. There is chances of multicystic encephalomalacia in the growing baby. Risk of anemia is very common. Asphyxia or to the baby is dead due to premature separation of the placenta. Discordant twins. So here, what do you mean by discordant? Is the size inequality between the two fetuses. One may be big and the other may be small. One may grow high and the other may not grow. Growth restriction, pathological growth restriction in one fetus. Very common in dizygotic twins. Symmetrical IUGR in early weeks is at high risk. Asymmetrical IUGR common in second and third trimesters. Criteria for discordancy. When the measurement of abdominal circumference differs by 20 millimeter in both the fetuses, you say there is discordant. And the head circumference, a difference by 5% and a weight by 15 to 25%. For them, it's only by regular monitoring of the growth and the weight of the baby you can identify, and a vigilant surveillance of them can be done. What is called monoamniotic twins? 1% of monozygotic twins can go in for monoamniosity. There is risk of intrauterine death. Main factor associated with perinatal mortality are cord entanglement, 50%. Congenital anomalies, preterm delivery, twin-to-twin transfusion. Diagnosis in ultrasound, twins of same sex, presence of single placenta, and absence of interdividing membranes. By Doppler, umbilical cord entanglement can be seen. So for monoamniotic twins, monoamniotic, which has only a single sac over there, the mode of delivery is only cesarean section. Here, can you see this? This is a single sac monochorionic and there is no dividing of it. So it is monoamniotic, MCMA. Discussing about the conjoined twins, the ratio is 1 in 20 of monozygotic twins. Incomplete division of the embryonic disc, which takes place after 14 days. The fusion can be at the level of the thorax. We call it as thoracophagus, xiphophagous xiphoid process, pyophagus, ischiophagous, and craniophagous. The mode of delivery in such cases is cesarean section. This is thoracophagus. This is craniophagous. This is at the level of buttocks, ischiophagous. So these are some live examples of, the famous Yams twins. And you see their family, which has grown big enough. One complication, which I would like to discuss, is the twin-to-twin transfusion syndrome. And the other one is a twin trap or the twin reversed arterial perfusion. This leads to one type of picturization called the acardiac monster. Extremely rare. Here what happens is that there are connections between the two umbilical arteries and the affected twin, the non-viable twin, from the early development. Circulation is maintained by pump twin retrograde via umbilical arteries. Here what happened? The blood from the donor twin goes to the recipient twin, preferably via the iliac vessels, and therefore the donor twin goes to acardiac nature or doesn't grow at all, and the recipient twin grows. Here the disruption of the growth and development of the upper body takes place. Can you see here? Here the whole blood from here goes to here, and therefore this leads to formation of acardiac twin. There are different types are there: acardias caecephalus, acardias myelocephalus, acardias morphus. The ultrasound diagnostic criteria is absence of fetal activity, absence of heartbeat, continued growth of womb and an increasing soft tissue mass, undergrowth of the upper torso and normal growth of the lower trunk. Here, in acardiac or acephalus twin, pump twin is supplying blood flow to both its own body and that of its abnormal twin. Death from heart failure is a common complication. Close monitoring with consideration of early delivery is important, and selective feticide of the abnormal co-tip can be done. The other complication is twin-to-twin transfusion syndrome, when a monozygotic twin shares one placenta. One placenta causes one baby to receive more blood. One baby or the donor becomes smaller and the other one larger. The larger baby has excess urine and forms polyhydramnios. The donor stops producing urine and goes in for oligohydramnios, and this leads to preterm delivery even less than 24 weeks. Here, the donor twin to pump twin here becomes hypovolemic, IUGR, and hydranous, the donor twin. Here, the artery to vein connections are present. The recipient twin, which becomes big in size, hypervolemic, polyhydramnios is present and develop hydrops, leading to secondary congestive heart failure. Usually present in those babies which have same sexes. Monochorionicity is present with the placental vascular anastomosis. There is an increasing weight difference of greater than 80%, presence of polyhydramnios in the larger twin and oligohydramnios in the smaller twin. Amnio reduction is a life-saving procedure for the polyhydramnitic baby, and laser ablation of the vascular anastomosis also helps out. This is the example of the TTTS where one baby is small and the other baby is big. So by giving vascular laser ablation of these vascular anastomotic vessels, we can save the life of at least one baby. So, what is the antenatal management of twin pregnancies? Early diagnosis, diet, supplemental therapy, frequent antenatal visits, vigilant fetal surveillance, and prevention of preterm deliveries by bed rest, tocolytics, and steroids. Mode of labor could be natural labor or cesarean section also. The first stage management, a skilled obstetrician is required. Ultrasound is also useful in the labor room. Intravenous infusion system must be there. Careful fetal monitoring, availability of blood products, anesthetist, and resuscitative methods. The most common presentation where you see both head are down is a cephalic. The other presentation is one is cephalic and the other baby is breech. The next presentation is where the second one is breech and the first one is cephalic. During labor, continuous monitoring is essential. Liberal episiotomy, forceps delivery if needed. Do not give epinephrine or oxytocin at the delivery of the first baby because the second baby has to be delivered. Clamp the cord in between. Leave about 8 to 10 centimeters of cord for drug administration or for transfusion, and label the baby as first baby and second baby. After the delivery of the first baby, always assess the lie and presentation of the second baby. Do vaginal examination to confirm abdominal findings and rule out cord prolapse. If the second fetus is a transverse lie, we can go for external versions or internal podalic version under general anesthesia in OT, or you can go in for a direct cesarean section also. And if it is a longitudinal lie, do an ARM and try to deliver by vertex or breech by breech extraction. Complications of severe bleeding, cord prolapse are there. Inadvertent use of ergometrin will lead to fetal asphyxia and fetal distress. So after the delivery of the second baby, give 0.2 milligram of methogen with the delivery of anterior shoulder placenta delivery by the controlled contraction method, and continue oxytocin up to 2 hours after delivery, about 20 units as intravenous infusion. Patient is put in left lateral tilt. Okay, and little bit, and we go in for great cesarean sections in multiple pregnancy if there is associated obstetric complications like placenta previa, preeclampsia, previous history of cesarean section, cord prolapse or contracted pelvis. For the sake of twins, whether it is if it is a non-cephalic presentation, collision of heads to the brim, IUTR, conjoined, TTTS, and monoamniotic twins, we go for direct cesarean sections where we don't wait for a vaginal delivery. Difficulties in antenatal care. Fetal heart monitoring is not possible, it's not very possible, and it needs some expertise. Complicated maneuvers are also necessary and greater skill to deliver the baby vaginally. So This is called fetal reduction, selective fetal reduction, which is usually done at 10 to 13 weeks. The candidates for reduction are those where one baby is anomalous and there are lowermost presenting of the baby. Procedure is by giving ultrasound guided potassium chloride, and if the order of pregnancies is 3 or 4, you can reduce it. It is done in dichorionic multifetal gestation. So why we do so is to decrease the fetal loss of the available baby, reduction in the risk of preterm deliveries, and decrease in maternal and fetal complications. Problems are psychological problems and social problems has to be overcome. Thank you.